Prostate cancer, what every man should know. Coming up next on Call the Doctor.
Biochemical changes that go on in the body.
You are not alone.
Call the doctor.
Call the doctor.
Prostate cancer occurs in a man's prostate, a small walnut-shaped gland that produces the semen that carries sperm. Prostate cancer is one of the most common types of cancer in men, second only to skin cancer. While the disease is rare before the age of 50, experts believe that most elderly men have traces of it, and over 27,000 American men will die of the disease this year. The fact is, prostate cancer is one of the top 5 diagnosed cancer types in our region. And in Pennsylvania, the disease is as common in men as breast cancer is in women. The good news is that prostate cancer, when caught and treated early, has one of the highest survival rates of any type of cancer. That's because prostate cancer is slow growing and slow to spread. But this can also make it more dangerous. Due to a lack of symptoms, men can miss catching the cancer in its early stages. That's why it's important to undergo proper screenings and know the early warning signs. Tonight, we'll take a closer look at prostate cancer, its possible causes, characteristics, and treatment options. Welcome to Call the Doctor here on WVIA TV. I'm Paula Giangiacomo. Tonight, our topic is prostate cancer. Joining us on the panel are Dr. Gerald Gilbert, urologist from Delta Medics in Scranton, Dr. Tulika Garg, clinical investigator and fellowship-trained urologic oncologist at Geisinger Health System, and Dr. Christopher Peters, radiation oncologist at Northeast Radiation Oncology Center in Dunmore. I would like to remind the audience that viewers at home can participate by commenting along with the conversation at wvia.org/CTD. You can also submit your questions for future shows by emailing ctd@wvia.org or using the hashtag WVIACTD. Check our website for a listing of future programs. Now let's begin our discussion. We want to start off with the importance of getting screened. Dr. Gilbert.
Thank you. I would say this is one of the biggest issues when it comes to prostate cancer. There's a lot of controversy, including the United States Preventative Task Force, which recommended against screening for prostate cancer. I think the three of us, the panel here, would disagree that that is probably not the right way to go. If you look at PSA screening, it's absolutely saved lives. It came into widespread use in the early to mid 80s.
It's a blood test.
Absolutely, just a blood test, simple to do. That with a rectal exam is what screening is about. And if you look at the statistics, back in the late 80s, early 90s, about 45,000 men a year died of prostate cancer. About that time, PSA screening came into widespread use. And if you wouldn't mind showing that one slide, you could see that starting in the late 80s to early 90s, the death rate from prostate cancer peaked as PSA testing became more widely available. And then since that time has dropped progressively. And as you said in your introduction, it's down to 27,000 men a year, which is almost a half reduction in death rate.
Well, it's amazing. So why would there be a controversy to getting a simple blood test?
It's because it's hard to screen. The U.S. government spends a lot of money on screening, on testing for prostate cancer. There are certainly a lot of men who will then get treated or have procedures for prostate cancer that may not help them in the long run. That doesn't mean screening isn't the right answer. It means we have to do a better way of figuring out who, once we're screened and who we diagnose, who's better and needs to be treated, who doesn't need to be treated.
Let me get to an email question from a viewer. This Jim R. from Muncie asks, I'm a 52-year-old male whose father was diagnosed with prostate cancer when he was 80. I currently have no symptoms. When should I get screened?
So for somebody who has had a family member with prostate cancer, that's certainly a risk factor. But that being said, about 80% of 80-year-olds have prostate cancer, and oftentimes these are indolent cancers that likely won't take that person's life. And so for this person, I would recommend screening based on the current American Urological Association guidelines. So he's in that age group where you would get screening. And of course, the guidelines do recommend a shared decision-making approach to screening where you have a conversation with your doctor about the pros and cons of undergoing the PSA and digital rectal exam.
Well, Dr. Peters, if someone has a family history of prostate cancer, should they get screened when they're in the right age group, or should you wait till you have symptoms?
Yeah,
and what are those
That's
symptoms?
a great question. So screening, just to take a step back, really the definition is looking for, in this case, prostate cancer when there are no symptoms. And you're just kind of plugging along, going into your doctor and talking about what to do. Generally, whether it's the AUA guidelines or other organizations, ASCO, NCCN, generally, historically, that's been at around 50 years old. That being said, if you do have a family history of prostate cancer, and there are other risk factors, such as, for example, being of African American heritage, and others, then you want to discuss screening with your doctors. Generally, you start with your primary care doctor, and then they will do a rectal exam and a blood test, as the doctors described before. And if there's alarming features on that, then generally seek the counsel of a urologist. So that oftentimes there are no symptoms of prostate cancer until it's in its most advanced stages. And getting back to the points that we made earlier, we obviously want to see the patients before there are symptoms of prostate cancer, because that generally implies a more advanced disease with, frankly, less options to help that patient.
And to reiterate what Dr. Peters says, the vast majority of men who come to the office with symptoms, even if they have prostate cancer, don't have their symptoms from prostate cancer, but have it from benign enlargement of their prostate, which is one of the most common conditions on
So
earth.
if you have an enlarged prostate, that doesn't mean you have prostate cancer.
Correct. And you can have symptoms and have significant symptoms, have prostate cancer as well, but that's not causing your symptoms. So typically a man who comes to the office with symptoms is not going to have prostate cancer. And if he has prostate cancer, symptoms usually aren't caused by the prostate cancer. Dr. Peters is right in that if they have symptoms that are directly caused by their prostate cancer, then we've missed the boat. We've waited too long.
Okay, so if you're in your 60s, you should get screened?
The typical recommendation is starting at 50 unless you have a family history or of African American descent.
So it's around the same time where you should be getting screened for colon cancer?
Correct. It is very similar to that. And those recommendations continue up until the point that you have a 15-year life expectancy. And at that point, you probably shouldn't get screened. Prostate cancer takes a long time to cause symptoms or kill people. And if you don't have that kind of life expectancy, you shouldn't be screened.
Now, Dr. Garg, once you get the PSA test and the levels are elevated, what's the next step for that patient?
So typically we like to make sure that it isn't an elevation due to something else, or that it isn't some isolated number. So oftentimes we'll recheck it.
But what are they
within a certain
testing? A
time period.
protein? A protein?
Yes, it is. The PSA test is checking for a protein that is secreted by the prostate. And so then if we confirm that it is an elevation, then we typically talk with our patients about doing a biopsy of the prostate to assess if the elevation is due to prostate cancer.
Dr. Peters, is there any other form of screening instead of a biopsy? Can you get an MRI, a CAT scan, a bladder scope?
Right now, no. Right now, it's really what we discussed. And if you're looking for, if you have a clinical suspicion that the gentleman has prostate cancer, really the gold standard is a prostate biopsy done by a urologist. Once that's done, if a prostate cancer diagnosis is rendered by the pathology doctors, then that's really when you get involved in multidisciplinary evaluations. Again, and I'll sound like a broken record, is discussing with your primary care doctor, in this case your urologist, because they're the ones doing the biopsy, and generally an oncologist, usually a radiation oncologist, sometimes a medical oncologist too, if it's a more advanced stage. So once a diagnosis is rendered, that's really when the patients and their families need to sit down and discuss all their options.
And then what are the treatment options?
There are multiple, but the main treatment options in the United States right now are going to be active surveillance, which means just basically watching and keeping an eye on that prostate cancer and seeing if it advances over time. 2, hormonal therapy. Prostate cancer basically is fed by the male hormone testosterone. If you take that away, it will put it into remission. 3, some form of radiation, whether it be seed implantations or external beam radiation. Or 4, some form of surgery, which in this area and most of the United States is really robotic, which is a laparoscopic approach to prostatectomy.
Okay, so they don't have to cut you open.
Correct. So that's going
And
to be
recovery would be quicker.
definitely quicker, less blood loss. People go home feeling better. So those are the 4 main treatment options for prostate cancer. The interesting thing that's happened over the last 10 years of prostate cancer, and I think important to what Dr. Peters had said earlier, is that we have to distinguish those who have a dangerous cancer that we're going to worry about and treat versus those that don't have that kind of cancer. And a lot of that split doesn't come by CAT scans or MRIs, which lay people tend to want to have and think that's going to give them the answers. It really comes from our pathology report. And there is this thing called the Gleason scoring
Right.
system for prostate cancer. And basically what that means is I try to explain to my patients, prostate cancer grows in patterns. And when the pathologist looks under the microscope, he looks for the most common pattern and gives that a grade 3, 4, or 5. He then looks for the second most common pattern that particular patient's prostate cancer is growing in and gives it a grade, 3, 4, or 5. He adds those up to get this Gleason score. So commonly we'll see score 6 cancers. And I'm going to tell you, I'm in Northeast Pennsylvania 22 years. Those patients universally got treated 22 years ago. For the most part, now, those patients are watched. They go on active surveillance. And in our practice, where everybody got treated when I first got to town, we're now at an active surveillance rate of 30 to 35%. So a full third of the patients that are diagnosed with prostate cancer in our practice don't get treated. They get observed. Those higher Gleason scores put those patients at greater risk for eventual spread and death. And those then get treated based on their age, their health, and other parameters.
How successful are treatments?
Well, it's a great question. Very successful. Dr. Gilbert showed earlier the graph of the decline in mortality. Men have a lot of options, and I think that's a key point for the viewers, is that there's lots of things they can do. Active surveillance is a treatment option because those patients are being watched under their doctors, and if something changes, let's say their rectal exam becomes abnormal or their PSA goes up, there are options for them. When you ask the question about how successful their treatments, we generally break, again, we have limited time, but we generally break down on how to manage these patients best based upon risk factors such as what is their Gleason grade, what does it look under the microscope, what is their PSA, and not only the number, but what's the trend, how fast is it going up? We call that PSA kinetics or velocity. And then the rectal examination. Some patients who have most patients that we see, fortunately, have a fairly normal exam, but if you do a rectal exam and the prostate feels not smooth, it feels like a stone or rigid, that suggests more advanced disease. And obviously the treatments work best for the patients with low-risk disease, and then we have an intermediate risk category, then there's a high-risk category. So really when I'm talking to a patient, our first job is to break down what risk category do you have and what are the kind of the most accepted and standard treatments. But even in the highest risk patients, a key message is patients have options, and that's a good thing because in other types of cancer that we treat, the options may be more limited. So overall, low-risk patients do exceptionally well in all treatments, including active surveillance, 5-10-year survival rates well over 90%. Intermediate risk, depending on what series you read, there's not a lot of head-to-head comparators, but again, most times, whether it's with surgery or radiation therapy, patients have generally between 80 and 90% control rates, 5, 10, even later. And then the high-risk diseases are such a hodgepodge that's probably outside of the scope of this program because it really depends on what the exact parameters are. But last thing I'll say on this is, getting back to the screening, the reason why we think it's important to have a thoughtful conversation with your doctors about screening, so you're not going to screen the guy that's 85 years old and has multiple health problems, but a young man who this might be his only health problem who's got prostate cancer, we want to watch that because we can really help that gentleman and his family, in the long term survive this.
I want to get to an email question from a viewer. This person asks, is there any way to prevent or reduce the risk of developing prostate cancer, such as taking herbal supplements like salt palmetto extract? This is Ed M. from Warrior Run, Pennsylvania. Dr. Garg?
We don't really know a lot about options for prevention of prostate cancer, and there's a lot of discussion about that. There were some trials looking at certain medications that shrink the prostate, that whether they could be used to prevent prostate cancer, and they have shown some efficacy in lowering the risk of lower risk prostate cancers, which may not be clinically significant. But as far as we know, there aren't really any medications or herbals to address the risk of prostate cancer. But I think pursuing a heart-healthy diet, exercise, weight loss, all the things that you do that are good for your heart are good for your prostate as well.
Now, once someone is diagnosed with prostate cancer and treated successfully, does it affect their lifestyle at all?
Well, of course, and I think that's one of the big controversies in terms of treatment of prostate cancer. And that side effect profile, it varies based on what treatment they choose and their age and their pre-treatment status. The big issues in men, obviously, are going to be their continence, meaning are they going to wet themselves or leak urine after treatment with either radiation or surgery? And two, are they going to be able to maintain or have erections after treatment? And both of those answers are yes and no. And I hate to say that, but certainly both surgery and radiation gives patients risk of incontinence. I will have to defer to Dr. Peters on that the risk of incontinence is lower for radiation than it is for surgery, no question about it. Potency rates are about the same over the long haul. There's clearly improved potency, meaning a return of erections, if you're young and healthy. In other words, if you're treating men in their 40s or 50s, they're likely to recover their erections and do well from a side effect profile. You know, when you start dealing with men in their 60s and 70s, it doesn't work out quite as well in those areas. Continence, yes. Potency, no.
Okay. Now, Dr. Peters, you're the Director of Clinical Research at Northeast Radiation Oncology. Is there anything new in terms of advancements?
Yeah, there's a lot. And again, it depends on those risk categories we touched on earlier. Obviously, a lot of the research work that's done on a national level is looking at better patient selection for treatment or surveillance. And that, we've gotten a lot better with that on. It used to be only, and again, what we discussed earlier, the PSA and the rectal exam is the standard. That's a take-home message. But there are newer measurements through the urine that are going to be coming into mainstream that can predict who actually may need a biopsy. Let's say if the biopsy is negative, but we think you've got prostate cancer, and that's exciting. And then as far as treatments go, really all the treatments, we were talking before the program, surgery's gotten better through the years, much better. Radiation's gotten much better. Hormonal therapy, which causes lots of side effects, has gotten shorter in duration. We used to give hormone therapy, for example, for high-risk patients routinely, 6 months, 2, 3 years. And the more we learn about that, maybe we can give less, give patients better quality of life. And there's also, so there's clinical research trials going on with treatment that are ongoing, run through usually the National Cancer Institute, which are available locally. And then there are basic science research projects going on in generally academic centers throughout the country, including Geisinger Medical College now, the old TCMC. And so there are researchers even here locally looking at different ways of predicting the severity of prostate cancer. It's a long answer, but I could talk about that all day.
And I would be remiss if I didn't mention that you're also a member of a special task force that deals specifically with prostate cancer.
Yeah, thank you. About a year and a half ago, the Act 66 of the Pennsylvania Assembly established this prostate cancer task force. And really what it was charged the Department of Health in doing is creating a task force, a multidisciplinary task force, 4 physicians, many patient survivors, and then core basic scientists as well as epidemiologists. So it was an appointed task force by Secretary of Health Karen Murphy, who's a local person who we all know and love. And what it looked at was really trying to hone in on the screening, because we have, was referred to earlier, the United States Preventive Task Force had a report that came out that basically said, and we're summarizing, screening, you don't need to screen for prostate cancer. Well, that obviously needed to be challenged. So we were looking at Pennsylvania's specific statistics on incidence and mortality and trying to come up with a Pennsylvania specific guideline. And basically it's what we're talking about here. Screen men at risk, use advanced techniques including multi-parametric MRI, do rectal examinations. One of the things we put in the task force is make sure you get a rectal exam. A lot of men don't get that. And so that will be, the press conference for release Secretary Murphy is doing in early April. So once that's out, we hope that health systems and payers recognize the importance of getting the appropriate men screened. So that's really a summary. There's lots of stuff in there. It's about a 120-page document.
It could save lives.
We think it will.
I think it will.
And Colonel Jim Williams, who leads the PA Prostate Cancer Coalition, is basically an advocacy group, also a member of the task force. His organization will run with this. And I think that's where you're going to see traction. So hopefully it'll be impactful.
I want to get to another email question. Is the rate of prostate cancer higher in northeastern Pennsylvania, specifically Luzerne County, than the national average? This is from Grady W. of Wilkes-Barre. Dr. Garg?
Not that we know of. The incidence of prostate cancer here is pretty similar to national levels, although we do have an older population in this area, and so there's potentially a little bit higher incidence, but in general it's pretty similar.
And do we know what causes it besides family history or?
I mean, there's a lot of discussion about what causes prostate cancer, and ultimately we don't know for sure. There are some genetic syndromes, actually mutations in the breast cancer gene. So people who have female family members who have breast or ovarian cancer should think about screening for prostate cancer as well, because it does run in that genetic syndrome. There's also some discussion with the VA and Agent Orange being associated with prostate cancer. And there's lots of epidemiologic studies that have looked at things like pesticides and other environmental exposures, but nothing definitive in those areas.
Overall, there's really only one absolute, and that is age.
Age.
That is the only thing we can confirm positively as a risk factor for prostate cancer. The older you are, the more likely you are to have it.
And what are the survival rates? Like once you've been successfully treated, how long can you expect to live?
I think if you look at low and intermediate risk prostate cancer, if you are successfully treated with either radiation or with surgery, you have probably an 80 to 85% chance of being cured, meaning you'll never have a recurrence ever in your life. If you look, as Dr. Peters said earlier, at 10-year and 15-year survival rates, even if you aren't cured, you are very likely, survival rates 90% and higher, to be alive at 10 years.
What if it spreads to like your lymph nodes or other organs?
When you're diagnosed, if you have spread at the time of diagnosis, your death rate from prostate cancer absolutely increases, and that's
with any cancer.
That is, and especially with prostate cancer, where that window of opportunity for cure is lost, and you're really trying to manage their disease. But those patients tend to do worse than every other population of prostate cancer patients.
Are there side effects to radiation?
Yes. Side effects of radiation and surgery and hormones, really any treatment that we give. And that's what's often the driver of what a patient may choose to select as their therapy. So for the first patient we see, maybe for that patient they'd prefer surgery. Maybe the next patient we see with the same parameters, they may prefer radiation therapy. Again, it's a reason why you have usually long conversations, and often numerous conversations with your doctors. And I guess the other take-home message is most of the patients that we see have the opportunity to not rush into treatment. In other words, many of the cancers that we see, there's an emergency. Someone has and that can be true of prostate cancer. We see patients in the hospital with terrible problems with prostate cancer that spreads. But on average, patients have a chance with prostate cancer, once it's diagnosed, to sit back, ask questions, get their opinions, confer with their primary care doctor, I keep saying that, and really make the best decision for them, because all the treatments have side effects. Just to name a couple though, as Dr. Gilbert already said earlier, the prostate is basically connected to the penis, the bladder, and the rectum. So those are the organs that are basically at risk for side effects no matter what therapy you do.
Right.
And then hormonal therapy, which is often important in more advanced disease, has a different set of side effects. All fairly manageable, but it's very multidisciplinary. We were talking about that earlier. So you really can't do it alone. So the patient's really going to be involved with their physicians in going through this process.
And to reiterate what Dr. Peters says, in terms of timing, prostate cancer is never an emergency, almost never an emergency. So the patients do have the time to do their research, do their homework. One of the more common questions I'll get from a patient is they decide they want their prostate out and they say, "Doc, it's golf season. I don't want to take off golf season." And typically, most of those
wait.
patients, they can wait.
Okay. But the key is get screened.
I believe that firmly.
Yeah,
Great.
I agree.
Thank you. Once again, I would like to thank our panelists for participating in our discussion on prostate cancer. For more information and to continue the conversation, visit wvia.org/CTD. I'm Paula Giangiacomo for Call the Doctor. Thank you for watching.